Yeah, thank you. Thank you for the invitation to present our results on liver transplantation in patients with colorectal cancer. I have no disclosure. And we know that this is a common disease, and we know that many of these patients, they developed liver metastases, and liver resection is the only curative treatment so far. But just a minority of the patients are candidate for liver resection. And the patients that have a liver resection, most of them will have a relapse within 3 years. And people have come up with several different scoring systems to try to make a prognosis for these patients after the liver resection. And due to the high relapse rate, this well-known EORTC study, they tried to see if chemotherapy before and after the liver resection could reduce the likelihood of a relapse and extend the overall survival in these patients. The primary endpoint of this study was progression-free survival at 3 years, and the secondary endpoint was overall survival. And they obtained a significant improvement in disease-free survival, although many of these patients had the relapse 2 to 3 years after resection. And we know that these patients had good characteristics regarding overall survival. The median number of liver lesions resected was 1. They had good performance status. Many of them had a nodal negative primary, and many also have normal tumor marker levels. In 2006, we started this study in Oslo, in Norway, with patients considered non-resectable. They should have a good performance status, previous chemotherapy, and the primary tumor should have received curative treatment. They should have no extrahepatic disease. At time of liver transplantation, 38, 43, and 90% had received first, second, and third line of chemotherapy, and some of these patients had although also progressed on last line of chemotherapy. And we compared our results to a Nordic 7 study. That was a first-line chemotherapy study with oxaliplatin-containing regimen. And based on these figures, without the liver transplant, our patient should have a median survival of about 40 months. We published our first results when the first patient had been observed for 5 years. At that time, 21 patients were included in the study. And here we have compared our survival compared to a similar cohort of patients from the Nordic 7 study. And we had a 5-year survival of 56% compared to 9% in the patients receiving chemotherapy. And if we compared our patient to patient in the Nordic 7 having only liver non-resectable disease and age up to 65, we see that the size of the largest lesion was relatively similar with 4.5 versus 4.7 centimeters. And we also compared our patient cohort to the EORTC study, and you can see that the median number in our study was 8 lesions, and we had a patient with up to 40 lesions. In the EORTC study, the median was 1 lesion, and they accepted up to 4 lesions. And the majority of patients in the EORTC study, they had metachronous disease compared to synchronous disease in our study and the chemotherapy study. Although the 5-year survival seemed to be similar in our cohort of patients as in the EORTC study. The primary endpoint of our study was a 2-year overall survival. And we included a total of 23 patients. At that time, we stopped inclusion in the study and went on to another study. We have compared 2-year overall survival to patients having the ILTS technique, and some of our patients had considerably more tumor load compared to the patient having a resection, although the overall survival was at least as good in our patient. We have figured out that these 4 factors seem to be important for overall survival after liver transplant. So the patient might have a score of 0 to 4. and patients having a score of 4, none of them survived for 5 years. And those patients are considered the high-risk cohort compared to the patient with a score of 0 to 3, and that's the low-risk patient. PET-CT was important to exclude extrahepatic disease, but PET uptake in liver was also important for overall survival after liver transplantation. Patients having a high metabolic activity by PET-CT, they had a lower overall survival after the transplant compared to patients having a lower uptake. We have compared our result to patients having a liver transplant as standard of care for patients with hepatocellular carcinoma. And from this table, you can see that the colorectal cancer, both the low risk and the high risk group, had more extensive disease compared to patients with hepatocellular carcinoma. And when we compare disease-free survival, the patient with colorectal cancer had a worse disease-free survival. They almost all, after a long period of time, we know that all of them had a relapse in this first study. Although the overall survival at 5 years was similar in our transplanted patient with low risk compared to patient having a liver transplant as standard of care in HHC patient. There was a marked difference what happened when you have a relapse. If you have a relapse after transplant for HHC, you have a bad prognosis compared to a patient having a low risk of a colorectal cancer patient. The majority of the relapses that we observed was small lung metastases. They were diagnosed at the median size of 7 millimeters, and they increased at a slow rate, as I'm going to show you later on. And the patient that had pulmonary recurrence had a much better survival after recurrence compared to patient with relapse in the donor liver, although the difference is not that big anymore. This is a patient that was transplanted in 2007. 2 years later, she had a small pulmonary lesion, and that was observed for 2 years before she had a resection. The same patient now had developed a new pulmonary lesion, and she was resected last week. And retrospective, that lesion was probably present almost 5 years ago. We have published our result when we have compared the growth rate of pulmonary metastases in our liver transplanted patient having immunosuppressive treatment to a control group of rectal cancer patient. And from these figures, you can see that there was no increased growth rate on the liver transplanted patient on immunosuppressive treatment. All these patients had the diagnosis confirmed by histology. We have now observed patients for more than 10 years. And here, based on our score system, the patient have been observed for 10 years for survival. And 5-year survival is 64% in patient having a score of 0 to 2, and 10-year survival is 40%. The patient with an Oslo score of 3, the one that survived longest, had an overall survival of 86 months after transplant. And as the patient with a score of 4, none of them survived for 5 years. And here is the overall survival with patient having a score of 0 to 3 compared to 4. If we compare the overall survival in patient having progressive disease on all standard chemotherapy, patients receiving TAS-102 and regorafenib, they have increased survival of 1.4 to 1.8 months compared to best supported care. And we, in this cohort that we transplanted, have a significant longer overall survival. And this is one of the patients that had, the shortest overall survival. This patient should not have been included in the study. That was a violation of the protocol, since that patient probably didn't have eco performance status 0 and 1. There's a lady that was a body weight of 60 kilo, and the explanted liver was 4.6, and she had drained 5 liters of ascites at the local hospital the day before the transplant. We had 4 patients that had metachronous disease. They all had a relapse within 2 years, but they had a long overall survival from time of relapse. And 3 out of those 4 patients are alive 10 years after a liver transplant. The last patient died of a sudden death, probably cardiac related, although he had a relapse of the malignant disease. The patient there have good quality of life. We have measured that up to 3 years after transplant. There is a significant and clinically important decrease in global health score and physical function 3 months after the transplant when the patient recover, and 6 months after they are back to baseline levels. Patient having general symptoms related to the malignant disease as appetite loss, they seem to have worse prognosis after the liver transplant. And these symptoms might be important to include for selection of patient. This paper was published last year and showing that some patients may have a long survival without a recurrent disease. However, many of these patients had a long time from diagnosis of the malignant colorectal cancer to the liver transplant. And 10 out of the 12 patients, they also received a liver resection before the liver transplant. We have now started a new study, SECA-2 study, where we try to increase the overall survival at 5 years. So the inclusion criteria is more strict. All patients, they should have at least some kind of response to chemotherapy at time of transplantation. And at the time of diagnosis, these patients had a median FONG, a clinical risk score of 3, and at time of transplantation, it was 2. And the immunosuppressor used in this protocol is relatively similar to the previous one, and are listed there. The outcome, overall survival estimated so far is 83%. Disease-free survival is 35%. We have patients now that have been observed for 5 years without a relapse, and the patient having a risk score at 1 to 2 at time of diagnosis had a better disease-free survival compared to having a score of 3 to 4. And it might be also important with the number of lesions. These patients also, many of them had a relapse, and the most frequent site of relapse was pulmonary mets, and they received pulmonary resection of the pulmonary mets. And many of these have no evidence of disease. So is it justified to use donor livers for colorectal liver mets? This is data from US patient having a transplant, whatever reason, and they have a 5-year survival of about 55%. And they continue to retransplant a patient. So who should be considered for a liver transplant? We think that patients with metachronous disease and lymph node primary, they have an excellent 5 and 10 years survival. And also some patients in the low risk group might have acceptable 5 and 10 years survival, so they could be considered for a liver transplant. As you have heard, the fundamental problem is the lack of donor organs for patients that might benefit from this treatment. And Paul Daglina, he came up with this so-called rapid concept, where the patient just received donor segment 2 and 3. The patient have a resection of segment 1 and 3, and then they keep in place segment 4 to 8 so they don't have a small for size syndrome. And these patients have a CT scan every week. And the primary endpoint of this study was safety and the number of patients that was able to go through the second stage of the hepatectomy within 4 weeks of the first part of the hepatectomy. And we have included 3 patients, and they all increased in size of the donor fragment. The patient received a graft to body weight ratio of 0.28 to 0.46, and they all were able to go through the second part of the hepatectomy within 3 weeks. This is the ongoing study with liver transplantation in colorectal cancer in Oslo at the time being. The patient in the CECA-N study, they should be followed for up to 10 years. So we have some patients that still are in follow-up. The CECA-2 study is a study where we try to improve the selection, so the 5-year survival is going to be even better. And the RAPID study is ongoing, and then we have just started a CECA-3 study where we randomize a patient between oncologic treatment and liver transplantation, and we are using extended donor criteria for that study. We have also shown that liver transplantation, especially for the low-risk patient, is cost-effective compared to modern oncologic treatment. So to conclude, we think that liver transplantation might be an option for a highly selected group of patients with colorectal liver mets that's not resectable, and with the extended and rapid concept and including a living donation, that might also be an offer for some patient. But still, we think that this is work in progress and patients should be included in prospective studies. And thank you, and thanks to my colleagues, especially to Paul Dag Line. Thanks.
Thank you for this very provocative presentation. Is there any questions from the floor or discussion? Eric?
Yes, thanks a lot. Just to understand well, for the moment you have the 3 rapid procedures, 3 patients.
Yeah.
Yeah, okay.
Yeah. So far, 3.
It's Peter Lodge from Leeds. That was a really wonderful summary of all the good work that you're doing. I've been concerned to see reports coming through of live donation for RAPID, and I'm just not sure if the results are good enough yet. Do you have a view about whether live donors should be considered right now?
Well, we are in the process of discussing that with the ethics committee. I think that from a patient perspective, when they have no other treatment options compared to chemotherapy, and the patient that we have included in that study is patients that have expected a median survival of 6 to 12 months. And I think that I met a lot of patients and relatives that of those patients that ask if living donation is an option for them. And today we had to tell them that so far it's not.
Okay, thank you. Yeah.
One more question I just can't help but ask. I know that it's and I've been through your data quite a bit and was fortunate to be the opponent for Morten's PhD dissertation. What would you guess is the survival benefit that the patients have that you've transplanted? By that I mean, what's the 5-year survival minus what their survival would have been without transplantation?
Well, the 5-year survival is about, when we published the result, was about 56%, and now it's a little bit less than that when we have followed all the patients to death or at least to 5 years. But the patient that we excluded from the study, they had a median survival of 16 months. And we had 4 patients that was excluded due to malignant diagnosis in lymph node and frozen section at the time of transplant. And those 4 patients, they didn't have more extensive disease than the one that we have transplanted. And they lived for 2 to 22 months after the frozen section diagnosis. So I think you can have more or less the kind of result that you like to have if you just compare the patient with metachronous disease and that their only treatment option is palliative chemotherapy, then you're going to have an enormous difference, I think. But that depends. If you're going to increase patients with a huge number of lesions, I think then your results are not going to be that good. And the shortest overall survival that we had was the patient that I showed you that lived just 6 months after liver transplantation. So that depends on how you select your patient. But all of these had either no treatment option or just palliative chemotherapy.
Okay, thanks.